in order to move blood out of the heart, both on the left and the right side, it has to overcome resistance. Okay? We'll talk about the valves here in just a second. So in order for the right ventricle to move blood to the lungs, it has to overcome the opposing force that's keeping the valve shut. Okay? The same thing on the aortic side. In order to move blood out of the left side of the heart, it has to overcome the resistance or the back pressure that's holding the valve shut. Okay? All right. So, blood flow comes into the right atrium with the superior and inferior vena cava, and it passively fills through on diastole. Diastole is what?
Residual pressure.
It's relaxation, right?
Yeah.
Okay, so by definition, diastole is the resting pressure in the ventricles. Okay, the resting pressure in the ventricles. So in diastole, I want you to notice we're going to talk about this first valve. And this first valve is called the tricuspid valve. It's tricuspid because there are 3 cusps to it. Okay? 3 little leaflet type looking things, or cusps, not leaflets. And then each one of these leaflets, if you will, are attached to what are called chordae tendineae. Okay? And then the chordae tendineae are attached to what are called papillary muscles. They are muscles that hold that chordae tendineae. Okay? So, when the ventricle is relaxed, so it's contracted and now it's relaxed, the relaxation pulls the papillary muscles down and opens up the valve. The valve opens this way. Okay? Allows for that blood flow to come in. At relaxation. Okay? As that ventricle becomes filled with blood, we have an action which is called an atrial kick. And this will mean, you'll understand this, just bear with me as I'm explaining this, this will make more sense here in just a minute. Then what the atria do is with this atrial kick, they contract. So they squeeze whatever remaining blood that's in the atria, squeeze it through the tricuspid valve into the right ventricle. So when I have a ventricle like this, that's filling with blood, and I get an atrial kick, and it makes the wall go like this. What does that do? Stretches the wall. What's it do? Okay, it fills up, but what happens to my diastolic pressure? If it's a resting pressure, and all of a sudden I put more blood in it to squeeze the walls, okay, so my diastolic pressure is going to increase, but what does that allow for the snap of the ventricle?
It's going to make it greater.
Yeah, think about this. I got a rubber band, and I pull it, and then I pulled a little bit more with the atrial kick, and then let go of it. Right? So it's going to give me a greater snap. Okay? Like a new pair of underwear, right? You can sit there and snap that thing, and then as it ages, guess what? You lose that elasticity, don't you? Right? Same, so that rubber band deal. So think about it as I've got this rubber band, right? So blood is coming in, so I'm kind of pulling the rubber band back. All right, now it's kind of tense. Now the atrial kick, and then the snap of the ventricle to move blood out.
That snap of the ventricle, is that the dub?
Is that the what?
The dub or the lub?
That's a dub.
That's the dub.
Yeah. Okay. He's talking about heart sounds, things like that. Okay, so atrial kick finally stuffs the ventricle, and then whenever the ventricles get their marching orders to snap, that sudden expulsion of the wall itself closes this valve, because again, they open this way, so it closes the valve, so it doesn't allow for backflow into the atria, overcomes the pressure that's resistant in the pulmonary arteries because the lung pressures are really, really low. We don't want high pressure in the lungs. Okay? So overcomes the pressure gradient, moves blood out into the lungs. As soon as the pressure, the resistance is greater than the pressure exerted by the ventricle, what happens to that valve? It closes. Okay? Okay, so it's only gonna stay open as long as the pressure gradient is greater in the ventricle. Once it's down, it's gonna close. Okay, everybody with me? All right, so it goes to the lung, bless you. On the left side, and of course we know that this is all happening at the same time, okay? Let's talk about the left. So the left side comes in through the pulmonary veins. This is where it kind of gets confusing. Remember, the pulmonary artery is the only artery that transports deoxygenated blood. It's still got some oxygen in it, but, okay? The pulmonary veins come into the left atrium, all right? They go through the mitral valve at diastole, at relaxation, just like it did on the right side, so it passively flows through the mitral valve into the left ventricle, and then at the atrial kick, stuffs the left ventricle, increases that diastolic pressure, increases that resistance, and then at the snap, just like on the right side, closes the mitral valve and overcomes the pressure in the aortic valve to move blood out into the arterial system.
Real quick question, so that, I know you said it's happening at the same time, but
Mhm.
that's, when it's coming in through the pulmonary veins, that's oxygenated blood at that point?
Correct.
So it just got oxygenated
Mhm.
in the lung, okay. But you're saying it happened at the same time?
Yeah, it all happens at the same time. So as blood is coming into the right side of the heart, into the atrium, blood's coming back from the lungs into the left atrium. Blood flow is still moving passively down into both the left and the right. So on the right is deoxygenated, the left is oxygenated. Okay? Atrial kicks stuff both ventricles at the same time, and then the snap at the same time closes the tricuspid and the mitral valve and opens up the pulmonic and the aortic valve. So two sides of the pump, but the same thing is happening on both sides.
Right, okay.
Okay? Same thing is happening. And when they're happening on both sides, when the ventricles are both working at the same time and the atria are working at the same time, we call that syncytium. Okay? You'll hear that term. And syncytium means basically in sync. Everything is synchronous. It's working together.
What is it called?
Syncytium, S-Y-N-C-T-I-U-M, I believe, syncytium. S-Y-N-C-T, I have to write it down in order to do it, but you get the idea.
Yeah, I know.
Okay, so it's all in sync. So, now, why is the left side thicker?
It's got to overcome more pressure.
Right, so it's got,
to push more.
yeah, so
blood in.
over here, it only has to overcome the pressure in the pulmonary system, which we already said is low, isn't it? Okay? Over here, it has to overcome the resistance in the arterial system, which is much higher. Usually they say it's about a third, so a third of your pressure is what they're pressing against. A third of the pressure is compared to the system, to the resistance on the aortic side. So that's considerably less, okay? Because of the difference in the pressure, the pressures that it has to work against. And so that's why that wall, as we age, gets a little bit thicker, because as we age, hypertension is just something that physiologically happens. Okay, now we can help it by picking up weight and all the other things that happen, but just even being healthy, there's some changes that occur to your vasculature anyway that kind of bring your pressures up as we age anyway. Okay? All right, so we understand the diastolic pressure, right? So it's the pressure that's exerted against the ventricular walls at relaxation, okay? At that atrial kick, when that ventricle snaps, that's systole. All right? That's the maximum, that's the high number, that's the pressure, that's the resistance. Okay? So that's how we get systolic versus diastolic. Okay, diastolic is resting pressure, and then systolic is the pressure at contraction when it moves blood out. Okay? So is everybody good with the differences between those two? Okay, perfect. So blood flow moves fluidly, perfectly through one-way valves, everything works good. So you'll hear some valvular issues. You'll hear people say, I've got a prolapsed mitral valve, or I have a regurg, or something like that. And so typically what happens with that is that you have basically one of the leaflets isn't closing right. You have some when that ventricle contracts, it actually squirts a little bit of blood back. Okay? And so you're going to hear that when you ask patients, what's your medical history? Have any heart problems? Whatever they may say. Well, I have a bicuspid regurg or bicuspid whatever. Okay, so it's a valvular issue there. Okay? So, blood flow moves pretty good. So let's make sure we're covered all of these. Pulmonary arteries, veins, right atrium. There's your common carotids that are going up, your carotid arteries, right? You've got subclavian arteries, your carotids and subclavians. Any questions with any of these? The intraventricular septum itself, this thick tissue here, does have the ability, it does contract, and we'll talk about how that contracts here in a little while. So no questions with that. We'll talk about endocardium, myocardium, and epicardium here in just a second. Okay? Now, I want to talk about, we said thymus pump performance, etc. Okay? And so let's just say that, let's take a patient who has heart failure. You're going to see a lot of patients with heart failure. What does that mean?
If something's not working properly.
Okay? If you got a person that has CHF, congestive heart failure, what does that mean? How do they present?
Edema. It's again excessive fluid.
Okay? Okay, fluid, right?
Fluid is back
So-
out somewhere.
Okay, so run with that. Why the backup?
It's not pump the left sided. It's usually left sided
Okay.
heart failure.
All right. Can you run a little bit more? What happens?
So basically, instead of all of that blood rushing into your pulmonic vein there, or whatever the case may be, there's basically still some residual blood that are not, or that are going back into your, the superior or inferior vena cava. And then that blood not going in the direction that it's supposed to be, is going into other types of tissues. You know, that's
Perfect.
when you go into basically your interstitial tissues.
Very good. Very good. Excellent. Let's clean that up just a little bit, but perfect. Right on. So typically we have heart failure. These patients have CHF because typically a couple of problems. Number one could be valvular problems. The valve isn't opening up well. The wall gets too thick, okay, over a period of years. They've had hypertension, okay, maybe they haven't controlled their blood pressure. And so what? That muscle gets so thick that eventually it's too thick and it can't contract well, okay? So it doesn't move blood out as well. And the other thing is that acute myocardial infarction, or AMI. If I have a patient with a big AMI, is that muscle going to be pumping like it should? And the answer is no, okay? So anytime that you affect pump performance, you're going to have failure issues, okay? So let's take this for example. So remember what diastolic pressure is what?
Residual.
Resting pressure, right? That sits in the ventricles at relaxation. Let's just say I've got heart failure, all right? So this wall gets thicker, 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 thicker. It's not able to contract as well, okay? So if it's not contracting as well, is it moving all the blood out necessarily? Okay? So as it's not evacuating all the blood, I still have blood coming in from the top, okay? So what does that do over time to my diastolic pressure?
It's going to increase it.
Yeah, it's going to increase it because I'm not evacuating all the blood. Blood's still coming in and I still get that atrial kick. So because it's not able, because I have some residual blood in there, because it's not able to move it out real well, my diastolic pressures begin to increase. Do you see how that works? Okay. As that diastolic pressure increases, so does resistance. Okay? And if you remember that it's a 4-chambered pump, right, coming in from the top, as this thing is beginning to empty into the right ventricle, the pressure increases here. Where is the pressure going to back up to?
Pulmonary veins.
Well,
The lungs.
before that, it's gonna back up into the, go blood flow in reverse, so if it's gonna start to increase and back up in the left or the right ventricle, where's it gonna back up into? Into the atrium, so that pressure is gonna back up into the atrium, okay? The pressure in the atrium is gonna back up, the pressure coming in to the right atrium is going to back up. So in essence, because of this pressure increase, the pressure is backflowing back into the lungs. So if we remember, these pulmonary veins are coming from where? The lungs, okay? And so as it backs up into the lungs, I've got pressure that's backing up, but I've got pressure that's going to the lungs, and so I've got opposing pressures. Does everybody understand that part? Because blood's still moving to the lungs, and then I've got increased resistance from it in the lungs, okay? So remember alveoli. Okay, alveoli are basically very thin walled, so it's surrounded by capillaries. So what we have happening is that we have opposing pressures at the alveoli. And so when I have pressure that's backing up at the alveoli from the left side of the pump, and I've got pressure on the opposite side coming in from the pulmonary arteries, that resistance forces water into the lungs. Now, something else you'll notice with CHF patients is that they'll have that pink, frothy sputum. Okay, you've heard it referred to that, pink, frothy sputum? Well, that pink are red blood cells. So at the same time the fluid is being pushed over, then it takes over that, it takes red blood cells with it. So that's how they get that pink, frothy sputum. That's left-sided heart failure because the left side is not pumping blood forward well, so it's backing up into the lungs. Okay? Same principle applies on the right. Okay? If it backs up into the right side because of pulmonary hypertension, okay, so my pressures are higher than normal in the pulmonary system, well, guess what? This right ventricle can get bigger, or the diastolic pressures back up, and it backs up, just like you said, but it backs up into the system. Okay, so our liver gets swollen, we have ascites, we have pitting edema in our lower extremities, things like that. Okay, so those are the differences between the left and the right. The physiology is the same. It's not able to move blood out real well, so the pressures back up. Okay? Yeah.
I'm sorry, while you're there, can you talk more about, so what does taking blood pressure medication or those types of cardio, what does all those risk factors do for that whole operation?
Mm-hmm. Well, when you get to the stage of heart failure, the damage is done. Okay? I mean, the pump is not going to work. So these are our patients that are on Lasix, and they may have home CPAP. They may, be on some other medications, which are like ACE inhibitors and things like that that regulate. It's like a diuretic where they don't retain the water; they pee it out. Okay, because if they can keep peeing it out and things like that, then less backs up into their lungs. So they're really at medical management for that standpoint, regulating the blood pressure. Because if my blood pressure is high, that just increases the workload, doesn't it? Which can worsen it. So I need to be bringing that blood pressure down. Okay? So that's where they move into it. Now, as far as EMS things, you can give on CHF, these patients who are working hard to breathe, you can give them all the bronchodilators, all the albuterol it is that you want, but it's not going to do any good. Albuterol is not the problem. That's an issue I have, even with some of our own guys. It's like, guys, CHF, don't think about albuterol. You don't need that. These patients don't even need Lasix because they're not overhydrated. That's not the problem. The problem is the pump isn't working well. So what do? Well, we give them nitrates. We give them nitro. Because what do? Well, with nitrates, I decrease the container. I decrease the pressure. Right? We'll talk about nitroglycerin here in just a little while, in a little broader sense. So I give them that, and then I give them CPAP. CPAP has really been a game changer for EMS and even in the hospital. Because just as the alveoli where that resistance is causing the water and the red blood cells to come over, well, CPAP puts a pressure gradient against that, holds the alveoli open, and pushes all that back over into the capillary. So really the two key things for left-sided heart failure are gonna be CPAP and nitrates and morphine. Those three things.
You said it pushes it into the capillary, but would not push it back into the system if it's pushing it back?
Yeah, that's what it's doing. It's pushing it from the alveoli back across into the capillary, which will put it back into the vasculature. Yeah.
Wouldn't a diuretic still be a benefit in the short term in the field, just to kind of help relieve blood pressure?
Well, by the time you push Lasix, by the time you get them to the hospital, you know, it's not gonna have any immediate effects. Here's the thing about Lasix, and here's one of the reasons why, you know, the preference is to hold off. Because number one, it's not really gonna do any good initially, but it's not a fluid problem. What does Lasix do? It makes you pee, so you get rid of volume of water. But let me ask you this, how many of you, if we were to test your urine, would you come back dehydrated? Almost all of you. Same way with a patient. It's not necessarily a volume issue. It's not a hydration issue. They don't have this over volume of fluid. The problem is it's the pump problem. So let's fix the pump and do what we can, ventilatory support. Let the hospital kind of find out where they are when it comes to hydration, and is there anything that has to be done as far as diuresis, and then let them do it. Okay? My point is that we're so quick to throw stuff in that, you know, albuterols and Lasix, when in fact, no, that's not going to address the problem. The problem is the pump isn't working right. And how do we address that? Well, let's decrease the workload by giving them nitrates, decrease the resistance, the pressure, and then let's give them some pulmonary support with CPAP. Just those two things will significantly turn your patient around. Seen it over and over and over. Okay? All right, so any questions at all about the anatomy? So you're going to have to understand the anatomy. We also talked about blood flow, how the blood flows through the heart with this. Okay, you're just going to have to, you know, just memorization and kind of work through it in your mind, you know, and that will help you. Let's go ahead and take a quick 5-minute break. Stand up, get your coffee, and then we'll move on. So just take a quick 5 minutes.